So I'd like to explain what is Parkinson's disease. So Parkinson's, I am a neurologist. So Parkinson's disease is characterized by these four motor symptoms. Bradykinesia is a slowness of initiation of voluntary movement. It's mandatory for the diagnosis of Parkinson's disease. And the plus one or more of the following features, such as resting tremor or muscular rigidity, is required for the diagnosis of Parkinson's disease. However, the non-motor symptoms, including lower urinary tract symptoms, are also prevalent and severe in Parkinson's disease. So, Dr. Sakakibara examined previously the rat in PD. So compared to age-matched control patient, PD patient shows overactive bladder, such as urinary urgency or urgent urinary incontinence, but the mechanisms by which severe OAB is evoked in PD patients are unclear. So recent functional brain imaging studies suggested that many brain areas are involved in regulation of blood functions, so such as the prefrontal cortex and anterior cingulate and periaqueductal gray (PAG) and the ponta micturition centers are probably very important in involving the regulation of blood functions. And the PAG has multiple afferent and efferent connections, which plays pivotal role in blood filling and voiding reflex. And because I am a neurologist and I am very much interested in Parkinson's disease, so basal ganglia also might also play an important role in blood function. And because we previously showed that dysfunction in basal ganglia leads to rats in PD. So this is my hypothesis. So left sides represent a basal ganglion circuit, and right side shows the micturition circuit. So connections between the basal ganglia circuit and the micturition circuits are not well understood. But I hypothesize that probably major prefrontal cortex might connect the circuit of basal ganglia and circuit of micturition because major prefrontal cortex receives the output signals of basal ganglia via thalamus. So all the motor complications such as wearing off and dyskinesia are found in some PD patients with advanced stage almost 10 years after the diagnosis. STN-DBS, which is the high stimulation of subthalamic nucleus, alleviates motor complication. So it has also reported that the STN-DBS is effective for lower urinary tract. And STN-DBS might influence the activity of output signal basal ganglia and send signals to thalamus and major PFC. So maybe STN-DBS might modulate the activity of major prefrontal cortex and so the micturition circuit. So I will briefly explain the subthalamic nucleus deep stimulation is shown here. An impulse generator is implanted in subcutaneously, and the electrode is inserted stereotaxically into subthalamic nucleus or globus pallidus interna. So about 10 years ago, so although the exact mechanisms by which STN-DBS act on rats in PD are not well understood, they suggested that STN-DBS might improve OAB by restoring afferent urinary bladder information from PAG. So my hypothesis is that the prefrontal cortex is thought to inhibit involuntary voiding during urinary storage phase via PAG, which is known to have dense connections with PFC. And PFC, prefrontal cortex, also receives dense dopaminergic, noradrenergic, and serotonergic projection. These nucleus are also involved in micturition reflex from brainstem nuclei, suggesting that catecholamine in PFC might play a significant role in regulating micturition reflex. And STN-DBS was reported to improve rat in PD patient by restoring the basal ganglia, which eventually led to normalized afferent projection from PAG. So aim of this study is we aim to clarify the effect of PAG stimulation of catecholamine levels in prefrontal cortex. And we also aim to elucidate the effect of STNDBS by simultaneous stimulation of PAG stimulation to verify whether STNDBS normalized PFC catecholamine levels induced by PAG stimulation in PBD model rats. I'm sorry, it's very complicated background. So this is the method of our experiments. Experiments were performed under anesthesia in 6-hydroxydopamine. We injected 6-hydroxydopamine into medial forebrain bundle. So, and single lumen catheter were transurethral inserted into bladder to measure bladder pressure, which means we evoked isovolumetric bladder contractions. So stimulation electrodes were inserted into the left STN and PAG. We stimulate the ventrolateral PAG. And concentric microdirect probe was inserted into left medial prefrontal cortex. So this is an experimental procedure. So extracellular fluid was collected at 10 minutes interval like this during PAG stimulation, during PAG plus STN stimulation, and after cessation of the stimulation. The catecholamine levels were measured by HPLC. So average levels of catecholamine in diuretic days collecting during the first 30 minutes before stimulation were defined as the basal levels, and the levels at the following each point were evaluated as a ratio to basal levels. So this is the result of PAG stimulation on the blood pressure. So PAG stimulation significantly decreased blood contraction interval from 568 seconds to 342 seconds. So I'm sorry, figure is not shown. So adding STN stimulation PAG stimulation, which means simultaneous stimulation of both ST and PAG tended to increase blood intercontraction, but without statistical significance. So blood intercontraction interval returned to baseline after cessation of stimulation. This figure is not shown. And this is the result of the change in the catecholamine levels in prefrontal cortex. Blue line norepinephrine, red line dopamine, and gray line serotonin. So PAG stimulation, like here, significantly decreased the norepinephrine levels in PFC 20 minutes after stimulation. And norepinephrine levels were basically significantly decreased during PAG plus STN stimulation, and also after cessation of stimulation compared to baseline. And dopamine levels are also significantly decreased during PAG plus STN stimulation. So catecholamine levels did not significantly change during PAG plus STN stimulation compared to during PAG stimulation. Also, I'm sorry, this figure is not shown in this statement. So my discussion, PAG stimulation significantly decreased blood intercontraction interval with concomitant decrease in norepinephrine and dopamine levels in PFC, which might indicate that the increased afferent projection by PAG stimulation lead to reduction in norepinephrine and dopamine levels in PFC and worsen urinary frequency in PD model rat. So although adding STN stimulation to PAG stimulation tended to increase the blood intercontraction interval, these effects are not statistically significant and did not significantly change catecholamine levels in PFC. So these results suggest that STN-DBS do not normalize, unfortunately, do not normalize PFC catecholaminergic activity. This is catecholaminergic level induced by PAG stimulation in PD models. So my conclusion is that the PAG stimulation significantly decreased blood intercontraction interval with concomitant decrease in norepinephrine and dopamine level. These results STN-DBS do not normalize PFC catecholamine levels induced by PAG stimulation in PD model rats. Thank you for attention.
Thank you very much for the presentation. Please, it's open for discussion. Yeah. Martin?
Quite interesting. I have a suggestion for you, not a question. how you could further strengthen your data. If I understand it correctly, in every animal you measure the intercontraction intervals and the catecholamine concentrations. If your conclusion is correct, if you plot based on individual animals change in catecholamines versus change in intercontraction intervals, you should get a fairly nice and tight correlation. Because you have a big variability between animals. And if your hypothesis is correct, if you look at the changes in both parameters within each animal, then the correlation should be fairly strong. Whereas if the correlation is weak, then your overall conclusion becomes weaker. So I would encourage you to do this type of secondary analysis of your data when you get home.
Oh, thank you very much. I'll try later.
Okay.
Very interesting results and sometimes difficult to digest, but so just without PAG stimulation, nothing, no PAG, just the STN, subthalamic nucleus stimulation, has some effect on the bladder activity?
We previously performed only STN stimulation, so
increase
interval. Yes.
So at the time, without the PAG stimulation, they change the catecholamine levels in the PFC?
Yes. So
what happens?
So the levels of catecholamine in PFC decreased during STN stimulation.
Still improve the bladder overactivity. So kind of disconnection between that PFC catecholamine levels and the changes in bladder function.
We have to further examine what happened in PFC. Or for example, adding some norepinephrine or serotonin directly to PFC, for example, or SSRI or SNRI. So we have to check.
So you also check that the serotonin levels?
Yes.
Yeah, actually, recent paper from Hokkaido University has that some changes, PFC changes in pharmacological treatment of the PFC in serotonergic and drugs actually reduce that overactivity, that type of things happen. So
next, we are now undergoing the direct injection of serotonin to PFC. So what happened? So
in this model.
Yes.
I have a final question. Deep brain stimulation is used in humans. Can you explain to us to what extent your observations have relevance for deep brain stimulation in humans? Can it explain how it works? Can it, open new possibilities for treatment or something?
So it's a very difficult question because mechanism why STN-DBS is effective for motor complication is not well understood. So it is my future work. We have to examine further.
So it contributes to our understanding of how this particular mode of stimulation works. Do you agree on that?
Sorry?
Do you agree on that your observations add to our understanding of how deep brain stimulation works?
Yes.
You think so?
Yes.
Well, then we have gained something at least. Well, more questions?
Okay, then next presentation has the title. Okay.